Well, hello, Pam. How are you today?
I'm fantastic. I'm excited to see you and have one of our opening up conversations and throwing it all out there and letting people know what our perspective is without any bullshit, excuse me.
Yeah, and I really want to open up today. And let's be a little controversial, okay?
Always.
Um, and it's all about tongue tie. And so I was reading my subscription to the New York Times. This has been a month or so ago, and it was an article that was about doctors ripping off patients and doing tongue ties that are not needed.
Yep.
And it was a one-sided article. I tried to get a hold of the author of the reporter, but I could not because everything that was said is detrimental to these children who have tongue issues when they're growing up. They can't nurse, they can't swallow correctly. Because they can't swallow correctly, the tongue is not molding the jaws like we've talked about in previous episodes. And you have a lot more experience about this than I do. So I would like to really open up on this tongue issue and tongue tie issue and how important is it really to the your children that you love so much and in their development that will last all through their life if it doesn't develop correctly, the jaw. And you wrote a book on craniofacial development and how important it is.
That is exactly right. And like your book, it's a very easy read about, what to look for at different stages of a child's facial development. That article you're talking about, I just was looking for it, and it's called The Inside the Booming Business of Cutting Babies' Tongues. Ew. When you hear a title like that, that is intentionally trying to create fear and terror in people's minds without having any understanding medically and dentally about the craniofacial development of these children and just trying to create a sensational story. And I think stories like this are just nonsensical, ill-intended, and I wish people would go after people like this because this author specifically bastardized a few surgeons, specifically, I think in the New York, New Jersey area, that I think are doing very good and helpful things for these babies. Like you were saying, what a tongue tie is, let's explain that first to our listeners. There are different type of quote ties in the mouth. If you pull up your upper lip, there's a piece of flesh right up underneath your upper lip in front of your two front teeth. Those are called buccal ties. There's also a piece of flesh or mucosa when you lift up your tongue that ties your tongue to the floor of your mouth. Yes, just like that. Max demonstrating that. If you guys are watching our YouTube, you'll see that. But we're trying to explain it. So if you're listening, I want you to understand this. So that's called a lingual tie. If a lingual tie is too taut, meaning it's too restricting to the tongue to move correctly, the baby cannot latch well and it won't nurse well. Now, some babies are little survivors. They'll thrive and they could have a horrible tongue tie and not be and push through and still feed and nurse and do okay. This is to the detriment of the mom's nipple because it really, really hurts. And that poor baby is usually termed as being colic or gassy or crying because what's happening is when the tongue is tethered down too tightly, the way you swallow, that undulating pattern is not done correctly. So that baby constantly swallows air. And then hence they're gassy or fussy. Or sometimes it's so tied down, like my oldest son, he had a severe tie. It was like to the tip of his tongue, no range of motion, and could not feed at all for the first 3 months of his life. He was not thriving. Was declining every day and becoming jaundiced and losing weight. And it took us, I say 3 months because it took us 3 months to get in at that time with a pediatric ENT to have his tongue clipped when it could have easily been done in the hospital when I told the doctor, my son has a tongue tie, and she told me he'll grow out of it. And I foolishly, I was said, okay, because back then I was a nicer and calmer human being. I am calm and I am nice, but I was too passive. Where'd those eyebrows go?
I've got to say something here. I've got to say something here. If you're a patient, you're paying the doctor, you're paying the hospital, you're paying the nurses. They're working for you. And the more knowledge you have, the better off you're going to be. And you have to stand up for what you believe in. But this is so important. If you're pregnant, you need to start thinking about this right now and finding you a pediatrician who will listen to what you say, because everything Pam is saying is right on. You have a personal experience, right, with your son.
Correct.
This is not something you read. This is not some study that you read. This is you, Pam Marsban, with your son, your beautiful, wonderful son, that you had to go through all this, and the child had to go this for the first 3 months. And if you didn't have any kind of education at all, what would it be like today with your son?
Oh,
It's
well,
really
he would have
upsetting to me.
he would be depressed. He'd had anxiety. He'd be scrawny. His posture would be horrible. He'd probably have a hump in the back of his neck, and he wouldn't be thriving like he is in school now. And listeners, like I was a dentist then, and I didn't have the background I do now. My son is 21 years old, but I knew that there was something wrong. And the fact that he couldn't feed, he was crying all the time, was gassy. He would have less than 2 ounces of milk and fall asleep because he was exhausted. It was horrendous. And then I had to advocate, and I was like, this isn't going to go away. This is ridiculous. Why was I so nice about it? Mac, you hit it on the spot. As doctors, we are here for you. And I know it's sometimes difficult to feel like you're going against a doctor, but you're not. If something doesn't make sense to you, follow your instincts and advocate for yourself. But anyway,
One little thing before I forget, then you please proceed. I look at these phones like guide wires on a tower. These towers and the guide wire is there to hold the tower in place but if it's too short, it's going to bend the tower over. It's not going to work right,
right.
So there's common sense. And so parents can look in there and see, that's not right. That's too short. I mean, back in the old days, the midwives had long fingernails where they, they clipped it as soon as the child was born.
Exact. And that's how it's still done in some third world countries. They understand that. To go back to the frenums or the tongue ties, if that tongue is tethered down, like you're saying, too tight, it doesn't let that tongue swallow correctly when the baby feeds. So when your child is an infant, that's the best time to diagnose this. It doesn't have to be at the very tip of the tongue. Sometimes it's in the middle of it, underneath the tongue, it's still tied down. So things that moms you can look for when you're feeding your baby, is the baby making noise when they are sucking and nursing? Is the baby's tongue coated white? Because the tongue should not be coated white. If the tongue is swallowing correctly, it's wiping the tongue from the milk up against the palate each time. Those are easy ways to look for it. If your baby is gassy all the time and not feeding well, they're struggling. And I know some of you are working with lactation consultants, but it always goes back to like, where did they get their trainings? Because I've been ill-advised by lactation consultants as well. So if they don't know really what to look for and all they're looking for is the tip of the tongue, they're going to miss it. And then if this is missed or undiagnosed or misdiagnosed, as the baby's jaw is developing, the tongue is not on the palate. So the roof of the mouth is not being developed wide or forward enough. And Matt brought this term up and I love it. I'm starting to use it more in my conversations with patients. It causes a facial compression, meaning the face doesn't start to develop forward. There's a mid-face deficiency, but just think the face starts to compress back and the child's face starts to develop flat. And as they become a teenager, it starts to develop long and even flatter. And as they get older, it just continues to go down that path. So there is a point in time in doing these frenum or frenulectomies, which is under the tongue or tongue tie release, a frenulectomy. There is a point in time for them. They just have to be diagnosed correctly and done at the right time.
Yeah, and there are rules for that, or there's, protocol for the right time.
Correct. The best time is if you can diagnose it at the time of birth, get it done there. Because if the mom is willing to breastfeed the baby, that is the perfect exercise for the tongue to not reattach. By the way, I don't think we've ever discussed what myofunctional therapy is.
We have not.
Okay. So a myofunctional therapy, myo means tongue, functional is function, therapy is therapy. So myofunctional therapy is like physical therapy for the tongue. And there are actual myofunctional therapists where that is their specialty. The best myofunctional therapy is breastfeeding. So if we can have that when the baby's an infant, they get the best results. So when my son's tongue was released, when he had his frenulectomy and he latched on to my breast, the tongue started functioning correctly and the tissue healed correctly. Okay. So his posture is great. His jaws developed beautifully for a number of reasons, but that was the most instrumental moment in his life. Now, if it's undiagnosed as an infant, man, you cannot do tongue releases on toddlers. People do, and I respect them and I love them for trying. But if you can't argue with a toddler. They're like little terrorists, they're cute little terrorists. You cannot argue with them. And the key to a tongue tie release being successful is the myofunctional therapy. And toddlers are not breastfeeding anymore. And if we can't get them to do certain exercises so the tongue heals
Oh, that
correctly,
makes sense.
it will reattach. So we put that child through a procedure, parents paid for it, they went through the suffering for what? I mean, it is a procedure, right? It is a surgical procedure, minor, but still. So I don't advocate for tongue releases between the ages of 1 year to 4, maybe 5 years. I just won't do it. I have done it and was not very successful with it,
So
honestly,
that,
right?
yeah.
I'm opening up.
Children are not little patients. They're a whole new category
They
because
are.
it's a whole new category, whole new game.
The
So,
procedure itself is not difficult. Like, I'm not going to say that it's super hard. I have a CO2 laser, and we could talk about different lasers and the best ways to get frenulectomies done. But I want to go into the timing of things. So if we miss that time and the child's 5 years old, or you can do a frenulectomy from any time from 5 until you're 90 years old if you want to,
right.
and do it for different reasons at different ages. When we're growing, it's for craniofacial development and airway. But I digress, I tangent. So the most important thing is when they are past the infant phase, they need myofunctional therapy on the front end of the procedure. They need to learn how to use the tongue right. Let me use the analogy I tell my patients all the time. If you are wanting to make your bicep bigger, okay, and you extend your arm out all the way, but you cannot flex it up to your shoulder, you're kind of stuck, at like a 30-degree angle. You can only build that muscle, but so far because you had that tie, you had the restriction, but you still want to tone that muscle. And that's what doing myofunctional therapy on the front end does. It starts getting the muscles to work better, but it can't do what it needs to do because it's still tied. Then you do the release. So now you have that full range of motion going, and it is critical for them to continue the exercises anywhere from 6 weeks to 6 months, maybe even a year sometime, depending on the age and the severity of the tie. That's the most success. That's the best type of combination therapy to make that patient be as successful as possible. And because the exercises are painful in the beginning after the procedure, it hurts for a couple of days. I've had it done, so I know I've done it for my sons. You can't argue with the toddler and get them to do the exercises if it hurts. They don't want to hurt themselves. They're like actually stretching through a wound. over and over and over again. And it's really for 2 to 3 days, because we also use a second type of laser to promote the healing and decrease the soreness after the surgery is done. And it's not that bad, but I mean, it's still a procedure, right?
Yeah, it is. So, but myofunctional therapy, just for your listeners, Pam and I are both on the board of the International College of Craniomandibular Orthopedics. And this, what we're talking about and have been talking about, is something that our organization teaches. And because we do teach, we get to meet the movers and shakers of these different disciplines like myofunctional therapy. And Joy Mueller is one of the pioneers of myofunctional therapy, and she asked me to write a chapter in her book. So if you want to know more about what Pam's talking about, her book is called Is Your Tongue Killing You? And it's also on Amazon. So the more you know, the more you're going to take care of yourself and take care of your family. This is great information, Pam, and it's so important.
You
So
know,
important.
we talked about CBCT imaging on our last episode, which is that 3D imaging we were talking about. And, we really went into a lot about the hard tissue, like using it to see where that TM joint is, and, how I make orthotics, and how you did too. Um, but I also mentioned that we use it for soft tissue meaning see where the tongue is and where the palate is and what the tissues in the nose look like, the turbinates, the adenoids, the tonsils, etc. And one of the ways I use it, because just yesterday we had an adult male come into the practice, both of his children needed orthodontic treatment because their tongue was never in the right place. And of course, he's like, I think this was me. And he came in wanting to do a tongue release on him. You can't just do tongue releases on anybody. Please understand that. And I think that's when people get in trouble, okay? Is when they do tongue releases on a mouth that's too small and narrow, meaning the child's jaw development's already started. It's not an infant, okay? It's not malleable, it's not bendable that easily, but the jaw is already developed, and in an adult, it's already sat. And then they have these tiny little crowded arches, so meaning the teeth are all crooked because the jaws are so narrow and the face is compressed back. If that patient's tongue tied, which we know they are, okay, that's why I got there to begin with, and you release that tongue, you can make their situations a lot worse, especially if someone has sleep apnea. That tongue can actually fall back in their throat and make their sleep issues even worse. So I'm not trying to scare people, but you have to have that understanding of, do you have the capacity? Is there enough space that if you release that tongue, it can have the space to start working correctly with the myofunctional therapy? Or is it just going to sit back down and heal to the same crappy position? Or is it going to fall in the throat and cause a possibly more dangerous situation for the person?
So 2 points here. One is that you didn't listen to your doctor. After 3 months, you knew something was wrong. And even though you're a dentist, it was common sense that told you that was something wrong. You were backed up by
I
your
knew
dental
it
degree.
immediately. I ignored myself.
So, but let's talk about your dental degree. What did you learn about tongue tie when you were in dental school? Not squat.
Nothing,
You didn't learn all of this.
nothing. We knew where the
And
was. That's it.
and what medical school teaches this? None of them. This is outside most of dental and dentistry and medicine. So this woman who wrote this article, this reporter, and I hope somebody that's listening knows her and tells her to call us because I'd love to talk to
Oh boy, let's go.
her. Let's go. Let's open up. And because your information is incorrect, you're talking to the wrong people. Are there dentists and doctors that rip the public off? Absolutely. That's why you have to have such a incredible relationship with whoever your healthcare providers are. I mean, they're doing you a service and you're paying them, but you've got to understand each other and you've got to get along and you've got to trust one another. And so what you're saying, Pam, is that this article, if people are going in there and cutting tongues left and right and causing apnea, you're 100% right. That's a travesty. but the way that she wrote it was just totally incorrect. And it's incorrect, not her fault, but it's not the doctor's fault. It's the unawareness of everything that has to do with TMD, tongue tie, nose breathing, mouth breathing, all of these different issues. They're all completely intertied with everything else. And if we're not treating all that together, and if we're not working with a team like you're working with a team there where you live, you're not doing the best job possible.
Correct. I mean, I have a certified myofunctional therapist in my office that's been working with me for 20 years. She's incredible. And I tell everybody the reason why my cases go and my surgical cases go that successfully is because of her and the patient's willingness to listen and do what they're supposed to do. They do their job, we do our job. It's a perfect combination for success.
Okay, so you have that person in your office
Mhm.
there for your patients. You have all this equipment that knows exactly where the joint is. You have this equipment that can tell you where the muscles are relaxed or not relaxed. You know, have a jaw tracker that tells you where the jaw is in space so that you can help these people. And this separates you from the doctor that says, well, maybe why don't we just try making you a night guard?
Right.
There's a little bit, there's a huge difference between the two.
Right.
So unless you've got somebody like Pam, you may not be in the right hands.
Thanks, Mac. Oh, thank you. And, I appreciate that.
But that's fact. I mean, we're friends and all that, but that is just fact. And the reason for these podcasts, the reason for my book is to help the person who is in pain, who's never had any answers, been kicked down the road, spent money, didn't work, and they don't know where to turn.
Right.
So
So, yeah, to recap, listeners, our goal is to have put out as much great content to help you understand the conditions you might be suffering from. Whether it's Mac's book, this podcast, whatever, is to help you because we know that I can't reach everybody, right? There's not enough doctors with our training out there to reach everybody, and people need to know how things went wrong so you can prevent it in your children and why you may be suffering yourself. That is our biggest goal with this podcast. And to go back to it, we get so upset and frustrated when there are authors or reporters that are just creating articles to create fear for sensationalism because it just is going to sound spicy and fantastic. That's just a bunch of nonsense. And it infuriates me because those people have no right, because now people are going to think that that's all the doctors are for, is to make
right.
money and to just hurt people. And Max said it right. I think you did great. There is a lot of good that comes with it. It needs to be diagnosed correctly. We can't fear it, but you must have that right relationship with your doctor because there are some people that are ill-intended. And you need to sift through that. You need to have the conversations. Frenulectomy procedures are life-saving. And I don't think that's an exaggeration because I've seen from the moment they're infants to the 80-something-year-olds that are suffering and have had a horrendous quality of life. If I had a penny, not even a dollar, a penny for every patient that said, I would wish I met you when I was a child, or 10
Right.
years ago, or 20 years ago, or 40 years ago. It's heartbreaking because at some point, some things are not fixable and we can make them better, but that ship has sailed.
And the ubiquitous patient comment is, why hasn't anybody ever told me this before?
Good God, that's so true. Anyway, I hope we're doing our best to tell you guys this,
Yes.
right?
I can't wait till we get back together again and hear what you've got to say.
Me too. Me too. So until next time.
All right. Later.
All right. Bye, listeners.